What's up, Ninja Nerds? In this video today, we're going to be talking about hypertension. This is going to be a part of our clinical medicine section. If you guys like this video, you benefit from it, it helps you, please support us. One of the ways that you can do that is by hitting the like button, commenting down in the comment section, and please subscribe. Also, highly suggest, we got a link down in the description box to our website. We got a lot of things there. We got merchandise, we have courses that we're starting to develop for step 1, step 2, your pants. Also, we have great notes, great illustrations that I think will be super helpful to follow along with during this lecture. All right, let's start talking about hypertension. So hypertension, first off, there's two types. There's essential, sometimes we call it primary hypertension. It's about 90% of cases. And then secondary hypertension. It's gonna be less common, anywhere from about 10% of cases. So on your boards, they love to test you on these, but in real life, most patients suffer with essential hypertension. So causes of essential hypertension, they're not well defined, but the concept of essential hypertension is relatively simple in the sense that, okay, patients who usually have essential hypertension are usually a little bit older, all right? And one of the problems with that is, let's say here we have a normal vessel. This is a normal blood vessel. And what we're gonna do is we are going to thicken this vessel up. So now we're gonna have a very thick walled vessel. Whenever you have a thick walled vessel, what you do is you reduce the actual diameter. Now it's a tiny little diameter because you thickened up the wall. That's going to increase your systemic vascular resistance. And whenever you increase systemic vascular resistance, what that does is that increases your blood pressure. All right, so that's one concept here, is that if you have a patient who develops a very thick walled vessel, it reduces the actual diameter, which increases the resistance. And when you increase resistance to blood flow, you increase blood pressure. All right, same concept here. Some patients, so have a very thick walled vessel, so increased thick walled vessel. What if I had a patient who had a normal blood vessel and it's super constricted? So some patients have normal blood vessel, give normal sympathetic tone to the actual blood vessel. And some people may have just a little bit more sympathetic tone where their blood vessels are a little bit over constricted. And so let's say that here we have a patient who has a little bit of an increase in their vasoconstriction. Same concept exists, that if you increase the vasoconstrictive mechanism, you make the diameter smaller, you increase the systemic vascular resistance and increase the blood pressure. So these are all things that can happen. The question that then arises is, okay, this is what occurs, what are the things that can stimulate this? Well, in thick-walled vessels, usually this can occur from people who are getting older, unfortunately. As you have advanced age, it's definitely going to cause more calcifications and thickening of the vessels. So age, as you advance your age, unfortunately. Another thing is smoking. So smoking is another really big one. And diabetes. These are all things that can really thicken up those blood vessel walls. For increased vasoconstriction, these are your patients who are usually very type A personality disorders. They're always very stressed out. So believe it or not, stressing out, that can definitely do it. So increased stress is another one. And here's another really interesting one, obesity. Obesity happens to be one of the biggest modifiable risk factors for patients who develop essential hypertension. So obesity causes a lot of cytokines to be released that really can stimulate this process as well. So these are some of the things that I want you guys to think about. The other concept here that's really, really interesting is some patients who have a very high sodium diet. So whenever you have a very high sodium diet, or there's some type of weird, there's these syndromes called Little syndrome and things like that, but sometimes if patients have extremely high sodium diets, it makes it difficult for the kidneys to be able to really kind of control that secretory function, right? And so what happens is if the kidneys are really struggling to be able to get rid of that sodium, but they don't do a very good job of it, sometimes you can have a lot of increased sodium in the bloodstream. And increased sodium in the bloodstream keeps water in your bloodstream. And so you have an increase in sodium and water retention. That will then cause more blood to be returned to the heart. So now you increase your preload, which increases your stroke volume. If you increase your preload and your stroke volume, you're going to increase your cardiac output. And whenever you increase your cardiac output, what's the formula that we should actually remember? Blood pressure is equal to cardiac output times systemic vascular resistance. So if you increase cardiac output a little bit, what are you going to do to your blood pressure? You're going to increase your blood pressure. All right. So if the sodium is having, the kidneys are having a little bit of a difficult time in being able to get rid of some of that excess sodium, or if you have like a genetic condition that makes it harder, you'll retain more of it and you'll cause your blood pressure to go up. These happen to be some of the most common risk factors, and usually essential hypertension presents in usually patients who are 25 to 55 years of age. Okay? So this is something else that I want you guys to be thinking about. Now, we're going to come back to this chart in a second. It's going to wrap everything up together. But we're going to come over here for secondary hypertension. So secondary hypertension, the age range is a little bit different. They could fall in the 25 to 55-year-old range, but what's the bigger tip to think about is these patients generally have what's called refractory hypertension. What does that mean? That means that you put them on an antihypertensive agent and they don't get control of their blood pressure. You put them on another one. You put them on another one. Generally 3 antihypertensive medications and their blood pressure is not under control. Start thinking about these causes. All right, so if you have a patient who comes in with high blood pressure, you kind of go follow them through. Then you have a patient, you put them on antihypertensives and you put them on 3 or more and they're still not controlled. Think about these. How do we remember these? Remember, it's a little bit out of order here, but renals, okay? I know it's a funky one, but renals. This is going to be by far the most common cause of secondary hypertension is renal disease. So when patients have renal vascular disease, the concept is pretty straightforward. Maybe their disease process is something like chronic kidney disease, or maybe they have something like renal artery stenosis. Either way, regardless of the cause, when the kidneys have some type of process where they are damaged, they frick up the actual GFR. They mess up the GFR. And when they do that, it leads to an increase in the renin-angiotensin-aldosterone system. And these things get jacked up. And you know what these do? We don't need to go through the whole mechanism. We should already know this from our basic physiology is that angiotensin 2 will lead to a lot of aldosterone, ADH, sodium, water retention, vasoconstrictive mechanisms, which would do what to your blood pressure? Shoot the blood pressure up. And that's what happens to these particular patients. All right, so I want you to think about that. So if you have a patient who has underlying chronic kidney disease, or you're auscultating their abdomen, you hear like a weird bruit, think about renal artery stenosis, think about CKD, or a renal vascular cause of their high blood pressure. Okay, next one is endocrine. Endocrine is an interesting one. And whenever we think about endocrine, I think 2 particular organs, the thyroid and the adrenal gland. All right, thyroid's funky, and it kind of makes it easy to remember, but it can be both. Whenever you got thyroid, if it's too high, T3 and T4, or too low, both of these can cause hypertension. You're like, wait, what? This is weird, man. If you got high T3, T4, you gotta stop eating thyroid. No, I'm just kidding, all right? But when you think about high thyroid levels, what this does is it causes your cardiac output to go up. It causes the heart to beat harder and beat faster. And so that will push your systolic blood pressure up. And so what happens with these is they increase cardiac output, which increases your systolic blood pressure. So you're gonna have an increase in cardiac output and an increase in your systolic blood pressure. We call this systolic hypertension. So the top number is gonna be super high. For whenever you have low T3 and T4, hypothyroidism, this normally controls your vessel tone. So it tries to play a role in kind of causing the vessels to dilate a little bit. But if you have very low levels, what do they start doing? Constricting. When they constrict, it increases your systemic vascular resistance, which increases your diastolic blood pressure. So the funky thing to remember about these is that this will cause diastolic hypertension, the bottom number, to be a lot higher. And that's the weird thing about these. All right, all of these, I'm not going to go through all of their mechanisms because we'll talk about them more in endocrine, but the adrenal gland, literally every possible hormone that you make here can cause this problem. So usually it's due to high aldosterone, high cortisol, or high amounts of epinephrine and norepinephrine. So if you have high aldosterone levels, this is called hyperaldosteronism. This will increase sodium and water retention. Cortisol, whenever you have very high cortisol levels, what do we call this one? Cushing's syndrome or Cushing's disease. This will cause increased sympathetic activity. And then increased norepinephrine and epinephrine. When these are higher, it's called pheochromocytoma. And all of these things will work through various mechanisms that I don't want to kind of bog us down in, but they will work to increase your blood pressure. And that's something I want you guys to be able to think about here. All right, so let's quick recap again. What are the causes of the endocrine problems that lead to secondary hypertension? It could be thyroid disorders, it could be hyperaldosteronism, it could be Cushing's syndrome, or it could be a pheochromocytoma. Let's write those down. All right, guys, so that is going to cover all of these parts for the endocrine disorders. Now let's come down for the neurological disorders. So it's actually pretty straightforward. So with the neurological diseases, it usually has to be some type of like neurologic catastrophe usually. Anything that increases the intracranial pressure, whether it's a bleed, whether it's edema, whether it's in cerebrospinal fluid, whatever it may be, a tumor, anything that massively increases the intracranial pressure inside of the brain will lead to something called Cushing's triad. So this is something that they can definitely kind of mess with you on the exam. If you have a patient with underlying like altered mental status and neurological deficits, and they present with these particular findings. One is bradycardia, one is high blood pressure, and the other one is irregular respirations. This should key you off to really think about some kind of problem here that's leading to this. So again, it would be Cushing's triad, such as low heart rate, high blood pressure, and irregular respirations. This is definitely a classic finding for someone having these particular findings. So if they have super high blood pressure, a low heart rate, irregular respirations, and neurological deficits, that could be the cause of their secondary hypertension. All right, the next one. You really want to think about this one, aortic diseases. You want to think about something called a coarctation of the aorta. So coarctation of the aorta. This is usually going to be something in very young individuals that you kind of see this in, but you see how it's a narrowing of the actual aortic lumen. Usually this comes after the left subclavian artery. And so what happens is it narrows, and then all this kind of like, look at this. You see how blood is supposed to be moving here, right? It's supposed to go from the left ventricle, supposed to go into the aorta, and now all this has to squeeze through this tiny little lumen now. All the pressure proximal to that little constriction point is going to be crazy high. So what you'll notice in these guys is that they will have an insanely high upper extremity blood pressure, right? They will have a very high upper extremity blood pressure because all of this is going to be super high in all the vessels proximal to this kind of like narrowing. So all the vessels going off to your arms are going to be super high blood pressures. But then you have very little blood going through the distal part here. And so what you'll notice is you'll notice a very low lower extremity blood pressure. And this is something that you definitely want to be thinking about as a potential cause. So if you see someone has like cyanosis of their lower extremities, they have low lower extremity blood pressures, high upper extremity blood pressures, think about coarctation of the aorta. All right, the last one here. This is actually super interesting. We're gonna have to bring this guy over here a little bit, but this is gonna be little people, just to finish this kind of like mnemonic a little bit. So this is little people. And this is really particularly for people who have what's called preeclampsia or eclampsia. So we're going to put here, this is going to be something like preeclampsia. Now, preeclampsia is usually, there's a patient who is usually in their like third trimester around that time frame, and they have a lot of proteinuria, they have a lot of edema, and they have a lot of high blood pressure. So whenever you see these kinds of findings such as edema, proteinuria, and hypertension in a patient who is pregnant, you want to start thinking about, could this be preeclampsia? Because if they start seizing, then you know they have what's called eclampsia. That's the only really difference between preeclampsia and eclampsia, seizures. So look for this. And the reason behind this is super kind of interesting, where they think that what happens is the baby is getting insufficient blood supply. And so what happens is the placental vessels start releasing chemicals, Whatever these vasoactive chemicals are, we don't really know. But these vasoactive chemicals, what they do is they cause vasoconstriction. So what they try to do is they really try to amp up the blood pressure. And whenever they amp up the blood pressure by really vasoconstricting, it's hopefully going to perfuse these placental vessels more and perfuse the baby. So it's an unfortunate kind of response that increases the maternal blood pressure and can lead to a lot of complications. But definitely something to think about in a patient who is pregnant. All right, we come to these last two to finish off the renals mnemonic. Now, substances. You always want to be thinking about this. If you have a patient with an altered mental status or they have some type of like weird activity, like they're diaphoretic, hypertensive, tachycardic, and they have a history of drug abuse, look for things that really, like, generally what they do is they amp up your sympathetic nervous system. Any kind of drug that really does that will definitely kind of like pump up the blood pressure. So if you have increased sympathetic medications, we call them sympathomimetics, that would definitely be one. What would be a potential drug that could do that? Cocaine would be one. And amphetamines. These are definitely going to be your big hitters that'll cause this type of effect here. So think about amphetamines and think about cocaine or even like PCP. These things will increase the sympathetic nervous system and increase your blood pressure. The last one here is sleep apnea. Believe it or not, this happens to be a big one. This is really becoming a very prominent one. And what happens is patients who have sleep apnea, they have periods of apnea. And during those periods of apnea, they don't properly oxygenate. So they develop very low oxygen levels during their sleep process. When you develop low oxygen levels, what it does is it activates your sympathetic nervous system. And whenever you increase your sympathetic nervous system, it's hopefully trying to get more blood flow to the lungs and get better perfusion to the lungs. But unfortunately, what it does is it clamps down on your systemic vessels. And these patients develop pretty high refractory blood pressure. So you want to think about this usually as a potential cause. If you have a patient who is obese, if you have a patient who has maybe a lot of somnolence, they snore a lot at night, maybe witnessed by their partner, and they have high blood pressure, think about sleep apnea related to secondary hypertension. All right, that covers secondary hypertension, right? So now what I need us to do is, we have a patient who has either essential or secondary. Secondary refractory to 3 or more antihypertensives. Essential, usually these are the features, and they're usually 25, 55 years of age and they have a family history. When these patients come in, you have to think about, okay, we've talked a lot about high blood pressure here as the cause of this disease. What is truly high? Well, when you look at this, normal blood pressure should be adequately less than 120 systolic and less than 80 diastolic. As they start getting their BP a little bit higher, maybe it's in between, it's greater than 120, but it's at least less than 130. Now we're at pre-hypertensive. Then we get to the patient who's stage 1. Their blood pressure is still a little bit high. We don't really like this. It's greater than 130, but it's at least less than 140. And in this particular situation, it's greater than 80, but it's at least less than 90. Then we get to the stage 2. This is a patient who's usually not very good. We don't like this. They are greater than 140, and they are greater than 90. This is usually where we get a little bit concerned when we see this for at least 2 or more readings. If we see this number for 2 or more readings, this is truly what we would consider to be, hey, this patient needs antihypertensives. Stage 1, if you're at that point and you have other comorbidities and a lot of risk factors, you could start medications. But what we really get concerned is when patients get their blood pressure up to greater than 180 systolic or greater than 120 diastolic. But there's 2 terminologies that we have to understand, and we'll go into more detail next. Hypertensive urgency is when this has a high blood pressure. Hypertensive emergency has this high blood pressure. So what differentiates them? Do they have target organ damage? I'm going to say that again. Hypertensive urgency is no target organ damage. Hypertensive emergency is target organ damage, but they both can have this high blood pressure. That is super important. All right, we've covered the pathophys of all of this. Now what I want to do is I want to say, why is hypertension bad? What are the complications? All right, my friends, so now we're going to talk about the target organ damage. So if a patient has hypertensive urgency versus emergency, systolic greater than 180 or diastolic greater than 120, and if they have target organ damage, it's an emergency. If they do not have target organ damage, it's an urgency. Now, patients who have target organ damage, is usually going to come in a couple different flavors. One is cardiovascular disease, neurological disease, renal disease, and retinal disease. These are the common features of injury and complications from high blood pressure. One of these is when patients have chronically high blood pressure, what happens is your afterload, right? So the pressure inside of the aorta is going to be super, super high, right? So when you have this like super high afterload, what does this do, right? So the pressure here is going to be crazy high. When you got this high afterload, what it'll do is it'll make the left ventricle have to work a ton harder. So now this left ventricle is going to have to get all kinds of thick. So it's going to trigger something called left ventricular hypertrophy. And that left ventricular hypertrophy will then make it almost impossible for the ventricles to be able to fill well, right? So now imagine this like space here, there's a very little space for blood to be able to come in. And so now this is going to be inhibited. And whenever you reduce filling, what can that lead to? Heart failure, right? Because it's going to drop the cardiac output. So these patients usually develop something called diastolic heart failure. This is super common, very, very, very common cause of patients developing heart failure. What's another terminology for diastolic heart failure that I want you guys to become very aware of? It's also called HFpEF, heart failure with a preserved ejection fraction, EF greater than 40%. That's one thing. Now, in acute scenarios where the afterload is super high, I'm talking really, really high blood pressure, it can make it really hard for blood to get out of the heart, and they can develop what's called acute pulmonary edema or flash pulmonary edema. That's something else to consider. All right. Next thing that I want you guys to remember is whenever patients have hypertension, what this does is this triggers atherosclerosis. Hypertension is definitely a trigger. You guys remember that mnemonic? I told you SAD, CHF, and the H was for hypertension. This will cause atherosclerosis, these plaques to develop within the vessel walls. If it develops within the coronary arteries, this will do what? Reduce the oxygen perfusion to the myocardium of the heart. That can then progress to what's called ischemia. Now, ischemia of the actual myocardium can look a couple different ways, right? So we can have this bland term called coronary artery disease, which could be stable, or it could completely progress to an MI. So sometimes if you have like a plaque rupture, this could potentially almost occlude the entire vascular lumen, and that could really, really reduce the oxygen supply, or completely occlude the oxygen supply. So that's one example of why hypertension can lead to atherosclerosis of the coronary vessels and lead to coronary artery disease or potentially MI. The other one is if it occludes the peripheral vessels in your extremities. Now your peripheral arteries are plaqued up, and now all of this tissue of the leg starts becoming ischemic. And this is going to cause a lot of pain to the muscles. It's going to start causing skin lesions. What's that called? Peripheral artery disease. So these patients can develop peripheral artery disease, and sometimes they can have significant ischemia to the limb, to where it's almost critical limb ischemia. So sometimes this is another thing to potentially remember as well. So atherosclerosis of the coronary or peripheral vessels is a big thing here. The last one for cardiovascular disease is when patients have hypertension, when that blood is just shooting. So imagine this, it's just plowing right here out of the left ventricle into the aorta. It's causing a lot of shearing forces within the aorta. If it shears up that aorta, what can that do? What is that going to do? So imagine here, I have a lot of shearing forces. You know, shearing forces is kind of like a lot of pressure against the actual blood vessel wall. When that happens, it's going to cause a tear. And now blood can start tracking in this. Look at this. It can start tracking inside of this lumen, this false lumen, if you will. So it's usually kind of this area between the tunica intima and the tunica media. And the blood can start tracking through here. What is this called? This is called an aortic dissection. So these high shearing forces can lead to an aortic dissection. That is another big, big thing that can happen and scary in patients who have super high blood pressure. All right, another one is that whenever you have these high shearing forces, the other thing is that this is going to cause it causes like damage to the vessels of the tunica externa that supply they call them the vasa vasorum. They become damaged, and they don't get enough blood supply to the abdominal aorta. And sometimes this thing gets super weak and it starts ballooning. And so another thing that you can get here is you can also get what's called an aortic aneurysm. So an aortic aneurysm can occur because of the shearing forces but it also can occur from like microvascular disease. So sometimes the tiny little vessels that supply the actual blood vessel itself, it seems weird, right? Blood vessels supply blood vessels? Yes, it does. Sometimes this can also cause an aortic aneurysm. And usually it's more common for it to be the abdominal aortic aneurysms. These are definitely going to be the most common in comparison to the thoracic aortic aneurysms. All right, so these are some of the big complications that we can see with patients having hypertension. Pretty terrifying, right? If these things blow, it's going to be a bad day for the patient. All right, another one, neurological disease. So blood vessels that are supplying the actual central nervous system or the spinal, brain and the spinal cord is another particular problem. Again, atherosclerosis is a very, very problematic thing. So if you start getting a lot of atherosclerosis that's occurring particularly on the blood vessels that supply the brain, this is also going to cause a lot of problems. So now this plaque is narrowing the actual vessel lumen. What it can do is it can actually really hit the carotids really hard, right around that bifurcation point. And this can lead to what's called carotid stenosis. And sometimes this may present as a TIA. So some patients may develop what's called a transient ischemic attack, where they have a very little blood flow that gets up in the brain, and this can actually lead to ischemia to the brain, and they can start exhibiting symptoms of neurological deficits of a stroke. But usually it resolves. Sometimes what also can happen is you can plaque up really big arteries, like the middle cerebral artery, other vessels like the vertebrobasilar artery, and you can literally block off blood flow to the tissues here, all right? And if that happens, you can literally cause death of the tissue. And this is called a cerebrovascular accident. So you can also cause a cerebrovascular accident because of these plaques narrowing the actual lumen of the vessels and limiting the oxygen supply to the tissues. Another terrifying complication. The other thing is, what if the pressure is so high that it's enough to rupture these blood vessels? Look at this, it just pops open, or it forms an aneurysm, and that aneurysm then bursts. So other things that you could potentially see here is you could see rupturing of the actual vessels, which can lead to things like an intracerebral hemorrhage or things like a subarachnoid hemorrhage. So these are all things that you want to be aware of whenever the patient has super high blood pressure. You rupture the vessels or you plaque up the vessels. Simple as that. All right, let's come back. We're going to come to retinal disease in a second. We're going to go over to renal disease. All right, this one's interesting. You kind of plaque up the vessels, but it's in a little bit of a different way. So whenever the patient has super high blood pressure, what happens is a lot of blood will be flowing through this thing called the afferent arteriole into the glomerulus, filtering and filtering and filtering tons of this filtrate into the glomerular area. What happens is that your GFR is just too high, and your kidneys don't like it when the GFR is way too high. So then what it does is it causes thickening or sclerosis of the afferent arteriole. So you're going to get what's called sclerosis of the afferent arteriole, or the renal vessels. We're going to put afferent arteriole, which is this guy here. What that does is that reduces the blood flow into the actual glomerulus and multiple areas of the glomerulus. This can lead to ischemia, and this eventually over time will cause renal injury. So renal injury. So you'll start damaging and destroying a lot of your renal cells. And what happens is when you cause this renal injury, this can potentially progress to something like an acute kidney injury if it's really, really bad, or a chronic kidney disease, which is actually going to be one of the more common causes of chronic kidney diseases, right? So there's two big causes, diabetes and hypertension. So this is a really, really high risk factor for that. So you have increasing sclerosis of this, which then stimulates ischemia, which then stimulates renal injury and can lead to these factors here. So this is another problematic issue that can arise. One way that you could tell is that sometimes this blood pressure is really, really high that it can just blow open these renal arteries, these actual glomeruli. And sometimes blood can actually leak into the glomerulus and into the urine. And this is another feature that can sometimes be associated more with AKIs. So you also want to look for, I'm going to write it here in red, hematuria, so blood in the urine. This also is a common finding here, that if a patient has an increase, because how do we define an acute kidney injury? It's an abrupt increase in the creatinine, right? CKD is there's a drop off in the GFR over time. So these are going to be big things to remember here. All right, the next one and the last one is retinal disease. So this one's interesting. So in patients who have retinal disease, we have different grades of hypertensive retinopathy, right? So we call this retinopathy. There's grade 1, grade 2, grade 3, grade 4. Obviously, as you go towards this 4, it gets worse. The concept is the same though. Usually what happens is these retinal vessels that I'm zooming in on, you get sclerosis first, so they get kind of hard and they reduce some of the oxygen supply to the tissue, the retinal tissue. Over time it progresses, and the pressure continues to remain elevated that it causes small hemorrhaging. That's the second part. And then lastly, potentially it can progress where it starts causing a lot of edema, tons of edema. And the way that this can look, if you take this pathophysiologically, you look at the eye, they may have these like tight little, like what's called AV nicking that you may notice on grade 1. As you go into grade 2, you may also notice, again, a lot of kind of like these constricted vessels. As you go into grade 3, you may notice a lot of these like tiny little aneurysms and what's called cotton wool spots. Then as we progress to grade 4, which is usually the one that they ask on your exams, especially during hypertensive emergencies, is there kind of like blurring of the optic disc? Is there a lot of swelling there around that area? And that's characteristic of what's called papilledema. So this is a big finding that you want to watch out for. More in the chronic stages, you may see again these cotton wool spots, these microaneurysms, these hemorrhages, AV nicking. These are some of the things that you might notice in the chronic stages, but acutely, you'll want to watch out for that one. All right, so this is the complications that you see with hypertension, usually again, target organ damage. So if a patient has a blood pressure that's greater than 180 over 120, and they have any of these features, we can call that a hypertensive emergency. Urgency, they just have a high blood pressure and they don't have any of these features. Over time with hypertension, it does cause a lot of chronic damage, and you want to watch out for that. Let's talk about the diagnostic approach. All right, how do we diagnostically approach high blood pressure? When a patient comes in, you want to get a BP in both arms. Reason why is you don't want to miss a patient who maybe has a high blood pressure and maybe they have an aortic dissection or they have some type of like weird subclavian stenosis or something that's altering the blood pressure within both extremities. So just make sure you check both arms in the office. Do they have hypertensive readings? In other words, is it stage 1, stage 2, or is it in the crisis stages? If it's high, I would have them come back to the office in anywhere between 1 to 4 weeks. Earlier the better though. Recheck it again. If I recheck it again and it's still elevated, the patient has hypertension. So you need at least 2 or more readings that are at least spaced out between maybe 2 office visits, and it's confirmed that in those 2 office visits, the patient has elevated blood pressure in both arms, they have hypertension. The one thing that you don't want to miss is something called white coat hypertension. So sometimes patients can have blood pressure because they're getting nervous and anxious coming into the hospital or coming into the clinic to get their blood pressure checked. But when they're at home, their blood pressures are normal. And these patients, make sure that you rule that out and have them check their blood pressure at home. We call this ambulatory blood pressure monitoring, and just make sure that their blood pressure is actually either elevated if you think that they have hypertension at home, or is it normal at home and only elevated in the office. That might make you think about white coat hypertension. The last thing is if a patient has a blood pressure of greater than 180 over 120, you have to then suspect, do they have a hypertensive crisis? Is there no target organ damage? Oh, then it's a hypertensive urgency. Is it positive target organ damage? Then it's a hypertensive emergency. And that's how we would go about determining a patient's diagnosis of hypertension, ruling out white coat hypertension, and determining if they have a hypertensive crisis and which type of that crisis it is. All right, now we come into the bread and butter here of hypertension. How do we treat it? So we have a patient who comes in, they have normal BP, less than 120, less than 80. Everybody in every aspect of life should be getting lifestyle modifications. You should always be trying to lose weight, eat better. The DASH diet has been one of the diets that's been shown to provide benefit. Exercise, reduce the sodium intake, reduce alcohol. Same thing for pre-hypertensive patients. When you get to stage 1, again, less than 140, less than 90, but greater than 130, greater than 80, in these scenarios, it's still lifestyle modifications. Here's what's different. If a patient has an atherosclerotic cardiovascular disease risk of greater than or equal to 10%, you need to start an antihypertensive. The reason why is because they have other factors that are making their potential risk of stroke or MI or peripheral artery disease much higher. And in that scenario, controlling their blood pressure is super, super important. So that's when we'll start them on a drug. Usually the most common drugs for essential hypertension is ACE inhibitors or ARBs, thiazide diuretics, or a calcium channel blocker, usually amlodipine or nifedipine, are super common drugs to use. If we go to the next one, stage 2, this is when they are greater than 140 or greater than 90. In these scenarios, you have to, again, institute lifestyle modifications, but right away start antihypertensives. You don't even care about their risk greater than or equal to 10%. If it's been consistently greater than 140 over 90, lifestyle modifications have not worked, you got to start antihypertensive right away. Again, use ACE inhibitor ARBs, thiazides, or calcium channel blockers. How do you know which one to pick? Generally, for most of these, you can pick any of them, but one of the things that they may try to test you on the exam is if they're African American. Calcium channel blockers such as amlodipine and nifedipine and thiazides have been shown to be significantly more beneficial in patients who are of African American type of ethnicity as compared to ACE inhibitors and ARBs because they have what's called low renin hypertension. And so I would actually consider that on the exam. All right. But oftentimes what the exam will try to do is test you as to what agent you'll use based upon the comorbidity that they have. Do they have another disease that would actually make you pick this drug over another one? So for example, did they just have a myocardial infarction? If they did, we all know that beta blockers are great. ACE inhibitors and ARBs are great because they reduce ventricular remodeling, and also beta blockers reduce the risk of VTAC or VFib, arrhythmias in general. Do they have heart failure? Same thing, beta blockers, ACE inhibitors, ARBs, but add on aldosterone antagonists. Those are the other ones to consider. Do they have coronary artery disease? Same thing, beta blockers, ACE inhibitors, or ARBs, but you can consider calcium channel blockers as well, diltiazem, verapamil, and amlodipine. The other thing that I would also consider here is when you're talking about coronary artery disease, nitrates have been shown to be beneficial. Isosorbide dinitrate, isosorbide mononitrate, these are drugs that you could potentially be instituting in these patients. The whole point of using these drugs in patients who have coronary artery disease is if they have associated angina. So angina, ACE inhibitors and ARBs will not be beneficial in angina, but beta blockers reduce contractility, reduce heart rate, that reduces myocardial oxygen demand. Calcium channel blockers, same thing, reduce myocardial oxygen demand. And nitrates reduce preload, which reduces the amount of work that the heart has to do to generate a good stroke volume. So these are the drugs that you'd want to give if a patient has angina as a result of their coronary artery disease and has hypertension. Atrial fibrillation, it's usually beta blockers and calcium channel blockers that would be your go-to choice here. And if they have diabetes and CKD, there's usually particular drugs such as ACE inhibitors, ARBs, that have been shown to reduce proteinuria and reduce a lot of the actual destructive damage. So they actually help with improving the patient's progression of kidney disease. So they have renal protection, but they also reduce albuminuria. So these would be the drugs that you'd want to give here. Pregnancy. I want you to remember the mnemonic healthy moms love nifedipine. And this is hydralazine, methyl-dopa, labetalol, and nifedipine. These are the drugs that have no teratogenic effect and have been shown to be beneficial in patients who have pregnancy-related hypertension. And then the other kind of ones that maybe kind of be scattered in there is osteoporosis. You want something that's going to conserve calcium. So hydrochlorothiazide is a really good one there. And then BPH is your alpha-1 receptor blocker. So doxazosin, tamsulosin. These would be the things I want you guys to remember. Now, things to quickly consider, but we'll go over this more in pharmacology, is beta blockers should try to be avoided in any reactive airway disease like COPD and asthma and acute decompensated heart failure because it can worsen cardiogenic shock. Calcium channel blockers, don't give these in acute decompensated heart failure. ACE inhibitors, ARBs, avoid this in patients who have an acute kidney injury or the potassium is super high. Same thing with aldosterone antagonists because these can increase your potassium and your creatinine. And then lastly, thiazides should be avoided in gout because they can cause hyperuricemia. All right, so how do we treat a patient who comes in with a blood pressure of greater than 180 over 120? I got to know, do they have target organ damage? Do they have any neurological deficits, any confusion, encephalopathy, any chest pain, or any signs of EKG changes? Do they have pulmonary edema or any evidence of acute heart failure? Do they have an aortic dissection, aortic aneurysm? Do they have an acute kidney injury? If they do, then we're going to go a different pathway. But if they don't, it's a hypertensive urgency. Aim to drop their blood pressure to less than 160 over 100, but use oral medications as needed. Okay, there's no need to rush to drop the blood pressure quickly. Get them down to at least the normal BP in 1 to 2 days, again, just to avoid any kind of like abrupt drop in the blood pressure because you don't want to cause ischemia, and we'll talk about that in a second. If they do have target organ damage, they have neurological deficits, encephalopathy, chest pain, acute heart failure presentations like pulmonary edema, aortic dissections or aneurysms or AKI, they have a hypertensive emergency, and you want to be really careful. You want to get the blood pressure down, but you don't want to get it down too quickly. So you want to drop the MAP by approximately 25% within the first 1 to 2 hours. Use IV agents, and we'll talk about those that can be utilized. After that, for the next 2 to 6 hours, aim to get them to the same BP here, less than or equal to 160 over 100. And then over the next 1 to 2 days, then try to normalize the blood pressure. The reason why this is super important, that you don't want to drop their BP too quickly, is if their blood pressure is super high and you drop it quickly, then you reduce the perfusion to that organ, and that can cause ischemia and then actually cause worsening organ malperfusion and target organ damage even more. So that's something to really, really be careful of. When patients come in, super high blood pressures, don't drop them too quickly, because you can cause worsening encephalopathy, worsening cardiac ischemia, worsening acute kidney injury. All right, so what are these IV antihypertensives that we can use? The choices are usually depending upon if you want to get their blood pressure super titratable and super closely controlled. So if I'm trying to actually titrate this to their blood pressure goal, usually IV agents, things like nicardipine or esmolol or nitroprusside would be the agents of choice that are nicely titratable. I'd say nicardipine is going to be the most common. Esmolol is good if they have any cardiac disease like CAD, MI, or aortic disease. Nitroprusside is one that can also be given, but I would really be careful because of the risk of lactic acidosis that can develop with this one. If the blood pressure is not as needed to be closely titrated, we can do IV pushes. And so we can give things like hydralazine or labetalol. So that would cover in this lecture hypertension. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.